This is the anatomy video for the lumbar spine, sacrum, and the abdomen. So we're going to start with the spinal column. We're only covering the lumbar and the pelvic curve here, but you can see from this picture the different curvatures of the spine. In the lumbar, the curve is called lordosis. So this being the front of the body and this being the back of the body. The curve is the vertebral bodies coming towards the front. And then that alternates and we have a kyphotic curve that occurs in the sacrum and the coccyx. Now with each individual vertebrae, in between them we have a disc. Okay? This is set up in the same alignment as you see from the vertebral column. So the anterior part of the disc is here, the posterior here. We have the annulus fibrosus, which runs around the outside. Think of it like the donut. And then in the center of the donut, we have the nucleus pulposus. And this is the area where we end up having disc problems. So when we're covering that in lecture, you'll be able to remember that the donut goes around the outside, and the liquid that's in the center is where we have a problem with the disc. Okay? With the lumbar vertebrae, we generally have 5 lumbar vertebrae, L1 through 5. Okay? The sacrum is generally fused 3 to 5 vertebrae, and then you have the coccyx at the end. If we get into each individual vertebrae, this is a vertebrae from the top. Okay, so we have the body of the vertebrae, we have the transverse processes that stick out the sides, the spinous process sticks out the back. This is the part you can feel if you feel on your backbone. And then we have these small areas which are the facets. The facets, or the articular facets that they mention here, this is the only part of a vertebrae that touches the next vertebrae. So if you look from the side, you have a facet that comes out the top, and then you have a facet on the bottom. This will then line up with the superior facet from the next vertebrae. Okay? The bodies don't touch. You have the disc in between. Okay? And those facets determine the type of movement that you get. So I will cover which way the facets point as we move into a few more slides. This is a picture of the sacrum and the coccyx from the posterior aspect. We have a spine, a sacral spine that runs down the middle. There is a canal that's carried on through the canal of the vertebrae, and then the coccyx is at the very end. So articulations, we have intervertebral articulations. So this is where the inferior and superior facets actually touch. You can see a good diagram of those here. So this is called a facet joint. Okay? And like I said before, the movement occurs in the facet joint. So the way that those point determines what kind of movement you're going to get in what area of the spine. So in the lumbar spine, the superior facet, the facet that's pointing out the top, faces medially. So if it faces medially, that's going to mean that it's going to determine that you can have a fair amount of flexion and extension, but it's going to limit the amount of rotation you can get. And you'll see that at the end when we talk about movements. The other thing you can see from this picture is the ligamentous support. Okay, there is actually a fair amount of ligament support in the spine. We have the anterior longitudinal ligament runs down the front of the vertebral bodies. We have a posterior longitudinal ligament. It runs in the canal. Okay, so it's running on the posterior side of the vertebral bodies. You have interspinous ligaments. They run between the spinous processes. And then you have the supraspinous ligament that runs on the back of the spinous processes. This is often the ligament in the cervical spine that's damaged with whiplash activities. Okay? You also have the ligamentum flavum, which runs more between the transverse processes and of the superior to the inferior. Okay? So ligamentous support is derived from all of these different aspects. Remember, when you get any whiplash type activity that occurs through the spine, all of these can be damaged. This is how you can get sprains to the spine. In the sacroiliac joint, we have the sacrum that comes down and meets with the ilium of the pelvis on each side. You have two main ligaments. You have the sacrospinous ligament, which is in the red on this side of the picture, and then you have the sacrotuberous ligament on this side of the picture. The sacrotuberous ligament is important for us because the bicep femoris of the hamstring muscle comes up and actually attaches on this as well as on the ischial tuberosity. Okay? So obviously the spine, we have the spinal cord and the nerves. They are contained in the vertebral canal, and they run from the foramen magnum, which is the very top, all the way to about L1 to L2. So your spinal column actually ends at L1, L2, and it becomes the cauda equina. So it tends to look more like a horsetail at the bottom. You have 31 pairs of spinal nerves that exit downward through the intervertebral foramen at each segment. Okay? The plexuses that we're going to have at the bottom here, we have a lumbar plexus, which is L1 through L4. We have a sacral plexus, which is L4 through S4. And then we have a coccygeal plexus, which is the bottom two, S4 and S5. Okay? Dermatomes are the sensory distribution of each nerve. So when you touch the skin on your leg, that is a sensory distribution. It's a dermatome. It comes from a certain segment of the spine. Myotomes are the muscles innervated by a single specific spinal nerve. Okay? We check these when there's damage to the spine or suspected damage to the spine. So this is a picture of dermatomes. This is dermatome man. And all of these little lines, you can see where the sensory distribution from that nerve is. So for example, L1 is right up here just below the pelvis. Okay? L2 runs across the front of the thigh, downwards L3, L4, L5. Generally then you get the sacral nerves up through the back. Myotomes are muscle contractions. So looking at this side, L1 does not have a movement, but L2 is hip flexion. So if you were concerned that somebody had damage to their spine, you could check these different movements, and if they could do these movements, generally you can be assured that there's not serious damage. Now, if they have weakness in these movements or can't do them, then that is the site where you're concerned about there being injury. And we will go through these in the lab so that you can try them. So back to musculature. Again, we're looking primarily at the lumbar and sacrum areas. There are two general differentiations of the musculature in the spine. The superficial layer of muscles, okay, that's this side here, extend from the vertebrae to the ribs. Okay? Erector spinae would be an example. Okay? That is a superficial muscle. The deep layer, which is on this side of the picture, extends from one vertebrae to another. So this includes quadratus lumborum, but it also includes these tiny muscles in here, the interspinalis, the multifidus, the rotatories, and up in the T and C spine you have the semispinalis. Okay? So of course then we have the lats that run over top of this, and the bigger muscles that run more through the T-spine, which is where we'll cover those. And again, we have those muscles that run in through the hip that attach to the sacrum. Primarily, we are looking at piriformis, which attaches directly to the sacrum, okay, and will have an effect there. And then we also have the gluteal muscles, medius and maximus, that are going to attach from the pelvis, and then maximus attaching onto the sacrum and the coccyx. So movements, in the low back, we have flexion. The amount of flexion is 40 to 60 degrees. Okay. We have extension, and that's 20 to 35 degrees of extension. Lateral flexion or side bending, we have 15 to 20 degrees. So there's that difference in where the facets point as to what movements are allowed. And rotation, we only have 3 to 18 degrees. Okay, now I know you're going to say that my spine moves far more than 3 to 18 degrees, but this is only through L1. Okay, you'll see as we get into the T-spine and the C-spine that we have more of those other movements like lateral flexion and rotation in those areas. The thing I want you to make note of is that 75% of our flexion occurs at L5S1. Okay, so L5S1 has the most amount of flexion in the low back. Okay, it is also coincidentally the most damaged disc in the body. We have another 15% of our flexion between L4 and L5, and then the remainder goes through the remainder of the L-spine. So it's no surprise that the majority of damaged discs are L4, L5, and L5S1, because that's where we have the majority of our flexion.